ഹലോ ജോണി.
ഗുഡ് ഈവനിങ് സർ.
ഗുഡ് ഈവനിങ്. കേൾക്കാവോ?
സുമാരൻ സർ, ഗുഡ് ഈവനിങ്.
ഗുഡ് ഈവനിങ് ജോണി.
കേൾക്കാം സർ.
കേൾക്കാവല്ലേ? കാണാവോ എന്താ വീഡിയോ?
കാണാം സർ.
ഓക്കെ. എന്നാ ഉണ്ട് പിന്നെ ന്യൂസ്?
വേറെ ആരും എത്തിയില്ല.
വേറെ ആരും എത്തിയില്ല. കാരണം ഞാൻ 7:45 ആയത്. അവര് നേരത്തെ ഇടുന്നതാ.
ആണോ?
7:45 ആ ടൈം. അതുപോലെ ഇപ്പൊ
ഓക്കെ.
ഭയങ്കര കടയല്ലേ എല്ലാവർക്കും.
അതെ.
ഭയങ്കര
പക്ഷെ ഇത് പാനലിസ്റ്റ് ലിങ്കാ സാറേ, വ്യൂവേഴ്സ് ലിങ്ക് അല്ല. കുറച്ച് പേരെ കാണുള്ളൂ. എനിക്ക് തന്ന ലിങ്കിൽ 7:30 കാണുന്നത്.
അതെ, എന്റെ ലിങ്കിൽ 7:30 നടക്കുന്നത്. അത് കാരണം നമ്മൾ 7:20 ആയപ്പോ കയറി. ഇത് നമ്മൾ നേരത്തെ വന്നില്ലെങ്കിൽ. പിന്നെ അടുത്ത പ്രസിഡന്റ് എലക്ട് കിട്ടിയോ ജോണി?
ഏകദേശം ഷിമ്മി സാറ് സമ്മതിച്ചു.
ഷിമ്മി സമ്മതിച്ചോ?
ഷിമ്മി സാറ് സമ്മതിക്കാൻ ബുദ്ധിമുട്ടായിരുന്നല്ലോ ആദ്യം. ഏകദേശം സമ്മതിപ്പിച്ച പോലെ. ഷിമ്മി സാറിന് മടിയായിരുന്നു ആദ്യം എടുക്കാനായിട്ട്. ഷിമ്മി സാർ ആദ്യം സീനിയർ ആണല്ലോ, നേരത്തെ സെക്രട്ടറി ആയിട്ടുണ്ട്.
അതെ.
അപ്പം മടിയായിരുന്നു ആദ്യം സാറിന്. ആദ്യം മുതലേ 2-3 കൊല്ലമായിട്ടൊക്കെ പറയുന്നുണ്ടായിരുന്നു സാറിനോട്. ഇപ്രാവശ്യം ഏകദേശം
മടിക്കേണ്ട കാര്യമൊന്നുമില്ല. ഷിമ്മി ഭയങ്കര ആക്റ്റീവ് ആണല്ലേ. നല്ല ഫാമിലി.
പിന്നെ അതെ.
പവൻ
സാറേ, ഗുഡ് ഈവനിങ്.
ഗുഡ് ഈവനിങ്.
എന്തുണ്ട് പവൻ?
ഗുഡ് ഈവനിങ് പവൻ.
ഗുഡ് ഈവനിങ് ജോണി സാറേ. ഗുഡ് ഈവനിങ്. സുമാരൻ സാർ സുഖമായിട്ടിരിക്കുന്നു?
കുഴപ്പമൊന്നുമില്ല, പോകുന്നു. ഗോയിങ് ഓൺ. പിന്നെ
കുറച്ചും കൂടെ ഫ്രഷ് ആയിട്ടുണ്ട്.
ഞാനിപ്പോ കുളിച്ച കറിയായിരുന്നു. അല്ല, ഇപ്പം ഭയങ്കര തിരക്കല്ലേ, ഹോസ്പിറ്റലൊക്കെ ഫുള്ളാ. IP ഒക്കെ ഫുള്ളാണ്. OP ഒക്കെ ഭയങ്കര തിരക്കാണ്. ഞാൻ വീട്ടിലെ പ്രാക്ടീസ് ഒക്കെ നിർത്തിയിരുന്ന, വീട്ടിൽ രണ്ടാമത് തുടങ്ങി. വീട്ടിലും തിരക്ക്.
റീസ്റ്റാർട്ട്
ചെയ്തു. ഹോസ്പിറ്റലിൽ ഭയങ്കര തിരക്കല്ലേ?
അതെ. എല്ലാ റെസ്പിറേറ്ററി കേസ് തന്നെ, ഫുൾ റെസ്പിറേറ്ററി കേസസ്, ഫുൾ
ബ്രോങ്കിയോളൈറ്റിസ്, ന്യൂമോണിയ.
അതെ.
റിപ്പീറ്റഡ് ആയിട്ട് തന്നെ വരുന്നുണ്ട് ഒരേ കുട്ടികൾക്ക്.
പിന്നെ ചുമ,
മാറാത്ത ചുമ. ഒരു മാസം കഴിഞ്ഞ് പിന്നെ അടുത്ത മാസം അതേ കുട്ടികൾ.
അതെ. ഈ പാരന്റ്സിനെ കൺവിൻസ് ചെയ്യാൻ ഭയങ്കര ബുദ്ധിമുട്ടായി തുടങ്ങി.
അവർക്ക് സ്കൂളിൽ പോവുകയും ചെയ്യണം, അസുഖം വരാതിരിക്കണം. അത് നടക്കല്ലെന്ന് ഞാൻ പറഞ്ഞു. സ്കൂളിൽ വിടുക, അസുഖം കിട്ടുക, ചികിത്സിക്കുക.
ഞാൻ ആദ്യം തന്നെ ചോദിക്കും, സ്കൂളിൽ പോയായിരുന്നു? അപ്പൊ പിന്നെ ആന്ന് പറഞ്ഞു കഴിഞ്ഞാൽ അതിൽ പിടിച്ചകത്തും.
സെക്കൻഡ് സംഗതി പ്രശ്നമായി.
പിന്നെ ഗവൺമെന്റ് സെക്ടർ പേഷ്യൻസ് കുറച്ചുകൂടി എളുപ്പമുണ്ട്. മറ്റേ പ്രൈവറ്റ് കേസസ് വരുന്ന കുറച്ച് വെൽ ഓഫ് ആൾക്കാരെ അറിയാലോ, അവരെ
പറഞ്ഞ് കൺവിൻസ് ചെയ്യണം. ഇപ്പൊ നമ്മുടെ ആരാ ഇതിന്റെ സ്ലൈഡ് ചേഞ്ച് ചെയ്യാനായിട്ട് നമ്മുടെ ഒരു സ്ലൈഡ് ഷെയർ മ്യൂട്ട് ചെയ്തൊക്കെയാണല്ലോ. നമുക്ക് ഷെയർ ചെയ്ത് നോക്കിയതാണ്. DIAP is not audible.
Host.
DIAP can test the screen sharing, please.
Yeah. Can you enable the screen sharing for Sumaran sir?
It's already enabled.
Okay. I will try.
Yeah, please try. Get to full screen, please.
Yeah, I will try. I'm trying for that. No, is it okay now?
Yeah, yes. Yes,
Yes,
sir.
Okay.
visible.
Okay, right.
Okay.
Then I will pause now. ഈ സൺഡേ ഇതില്ലേ മീറ്റിംഗ് ഇല്ലേ ഈ സൺഡേയില്?
ഈ സൺഡേ ന്യൂറോകോൺ ആണ് സാർ.
കൊല്ലത്തല്ലേ? കൊല്ലത്ത് ന്യൂറോകോൺ ആണ്. എല്ലാ സൺഡേയും ഉണ്ട് പ്രോഗ്രാം.
ഇപ്പൊ ഓണത്തിന്റെ ഒരു സൺഡേ മാത്രമേ ഇല്ലാതെ. ഒക്ടോബർ 30th ആകുമ്പോൾ തീർക്കണ്ടേ?
അല്ല ഒക്ടോബർ 30 9th ആണെന്ന് തോന്നുന്നു. റെസ്പിറേറ്ററി 9th റെസ്പിറേറ്ററി അല്ലേ?
അതെ.
അത് നിങ്ങൾക്ക് തലശ്ശേരിയിലില്ലേ?
കണ്ണൂര് സാർ.
അത് അല്ല തലശ്ശേരി ക്രിട്ടിക്കൽ കെയർ ഇല്ലേ?
ക്രിട്ടിക്കോൺ
അത് കഴിഞ്ഞിട്ടാണോ?
ക്രിട്ടിക്കോൺ അതിന് മുമ്പ് സെപ്റ്റംബർ 25th.
സെപ്റ്റംബർ 25.
ഒക്ടോബർ 9th കണ്ണൂര്, 16th ആലപ്പുഴ ഇൻഫെക്ഷ്യസ് ഡിസീസ്. പിന്നെ 23rd അലർജി ഉണ്ട് വടകര. അതോടെ കഴിയും.
അത് ഫിക്സ് ചെയ്തോ?
ഇല്ല, ഒക്ടോബർ 23rd ഇനി ഉള്ളു ഡേറ്റ്. അതുകൊണ്ട് ഇനി വേറെ ഫിക്സ് ചെയ്യാനൊന്നും നോക്കാനൊന്നും
ഇല്ല. 23rd.
സാറിന് 2 പ്രാവശ്യം വരേണ്ടി വരും.
അതെ വേണോ വേണ്ടത് ഇപ്പൊ ആലോചിക്കാം. അങ്ങനെ മീറ്റിങ്ങുകളൊക്കെ അങ്ങനെ
റെസ്പിറേറ്ററിയിലും അലർജിയിലും സാറില്ലാതെ പിന്നെ
പ്രശ്നം. മീറ്റിംഗ് ഒക്കെ ഒത്തിരി, അതുപോലെ ഈ സൂമും ഒത്തിരി കൂടുതലാണ്. സൂം മീറ്റിംഗ്
ഭയങ്കര കൂടുതൽ. ഗുഡ് ഈവനിങ് അനന്തകൃഷ്ണൻ സാർ. ഗുഡ് ഈവനിങ്.
IMA മീറ്റിംഗ് ഉണ്ട്.
പ്രസിഡന്റ്
അതൊക്കെ കഴിഞ്ഞു. അതല്ല IMA മെമ്പർഷിപ്പ് ക്യാമ്പയിൻ, അതിന്റെ ഒരു മീറ്റിംഗ് ഉണ്ട്. അതിന്റെ മീറ്റിംഗ്
IAP സ്റ്റേറ്റ് മീറ്റിംഗ് തൃശ്ശൂരാണ്, കുന്നംകുളം.
അതാ സാജു ആണ് അതിന്റെ ആള്. സാജു അല്ലേ? സാജു ആണ് ഓർഗനൈസ് സെക്രട്ടറി. സാജുവൊക്കെ ഇതിൽ വന്ന് ഫണ്ട് കൊടുത്തു. പോക്ക് നടക്കുമെന്നുള്ള.
കൊല്ലത്തേക്കുണ്ടോ? കൊല്ലത്തേക്കുണ്ടോ?
നിങ്ങൾ ന്യൂറോളജിസ്റ്റ് ഒക്കെ പോയത്? ന്യൂറോളജിസ്റ്റ് പോയാൽ മതി. കർണാടക വിളിക്കേ.
എടാ അത് താന്ന് പോയതാ? എന്തോ കരണ്ട് പോയതാണോ?
വിശേഷം? ഞാൻ ഒരു എന്താ പറയാ,
എന്നാ വീട് ഹൗസ് വാമിംഗ് എന്തായി?
സാറ് 2-3 വീടൊക്കെ കെട്ടിയിരിക്കുക. ഞാൻ ഒരു വീട് കെട്ടിട്ട് എന്റെ ആഴ്ച പകുതി കളഞ്ഞു.
ഹൗസ് വാമിംഗ് എന്താ?
തൃശ്ശൂർ ടൗണിലെ കൊട്ടാരം പണിതോണ്ടിരിക്കുകയാണ്.
ആ അതെ എനിക്കറിയാം പഴയ.
എന്നാലും ഇത്ര ചെറിയ സ്ഥലമല്ല, എത്ര പണിയാൻ പറ്റുന്ന അറിയാലോ.
മുകളിലേക്ക് പണിയാം, കുഴപ്പമില്ല.
മുകളിലോട്ട് എങ്ങനെ പണിയപ്പാ, പ്രശ്നല്ലേ?
പ്രശ്നമൊന്നുമില്ല.
തെക്കും വടക്കും കിഴക്കൊക്കെ അമ്പലങ്ങളാണ്.
എന്റെ ആനന്ദം അങ്ങനെ പ്രശ്നം എന്റെ പിടിക്കുന്നുണ്ടല്ലേ.
അമ്പലമാണല്ലോ സാക്ഷാത്. സാറ് കുറച്ച് മാറിയിട്ടല്ലേ, കുറച്ച് മുമ്പിലല്ല,
ഏറ്റുമാനൂർ ക്ഷേത്രത്തിന്റെ പുറകിലല്ലേ വീട്?
സൈഡില്. ആൾക്കാര് പറയും അമ്പലത്തിന് മുകളിൽ പണിയെന്നൊക്കെ പറയും. അതിലൊന്നും വലിയ
ഞാൻ പണിതു, കുറച്ച് പണിതു.
ഓ അതിൽ കുഴപ്പമൊന്നുമില്ലെന്നേ. നമുക്ക് പുതിയ വീട് വെച്ച പിന്നെ വൻ കയറ്റങ്ങൾ ഉണ്ടായിട്ടുള്ളൂ, അല്ലാതെ ഒരു ഫോൾ ഉണ്ടായിട്ടില്ല.
വേറെ വീട് കിട്ടുന്ന നമ്മുടെ സ്റ്റേറ്റ് പ്രസിഡന്റാ വിജയകുമാർ.
അത് ശരി, വിജയകുമാർ.
അപ്പൊ വീട് കിട്ടുന്ന കാര്യം പറഞ്ഞല്ലോ സാർ.
വിജയകുമാർ കാലിക്കറ്റാണോ?
കാലിക്കറ്റ് തന്നെ സാർ. അത് അവിടെ തന്നെ പഴയൊരു ഞാൻ വീട് വാങ്ങിയതായിരുന്നു. അതൊരു സിംഗിൾ സ്റ്റോറിയുടെ ആയിരുന്നു. അതൊന്ന് അപ്സ്റ്റേഴ്സ് കേട്ടുന്നുണ്ട്. സാറ് സാറ് വീട് ഞാൻ കണ്ടതല്ലോ, നമ്മുടെ ഞാനും അജിത്തും കൂടി.
നമ്മുടെ വീടിന്റെ അടുത്ത് തന്നെ സണ്ണിനോയും വീട് വെച്ചു.
അതെയല്ലേ സാർ? ഓ സാറിന് അടുത്ത ആളുണ്ടല്ലോ,
ജസ്റ്റ് നടന്നാ മതി.
അതെ സാർ, അവിടെ തന്നെയാ, അതേ സ്ഥലത്ത്.
ശരിക്കും അത് അതിന്റെ ഞങ്ങളുടെ അമ്പലത്തിന്റെ ഓപ്പോസിറ്റ് റൂട്ടുണ്ട്. വേറെ അമ്പലമുണ്ട്, വേറെ അമ്പലമുണ്ട്. അമ്മൻകോവിൽ വേറെ ശുണ്ടം.
ഗുഡ് ഈവനിങ് വിജയകുമാർ സാർ.
ഗുഡ് ഈവനിങ്
സാർ. ഗുഡ് ഈവനിങ്. ഞാൻ നേരത്തെ കേറിയിട്ട് ഇറങ്ങിയതാ. ശ്രീജിത്ത് ഗുഡ് ഈവനിങ്.
ഗുഡ് ഈവനിങ് സാർ. കരുണാകരല്ലേ ആനന്ദ്?
അന്നേരം സാർ ഹൗസ് വാമിംഗ് ആയോ?
ഹൗസ് വാമിംഗ് ഫാമിലി മീറ്റിംഗ് ഒന്നിച്ചാന്ന് തോന്നുന്നു.
കുറെ കാലായി കണ്ടിട്ട്. ഞാൻ അഡോൾക്കോണിന് പോയിട്ടുണ്ടായിരുന്നു കൊച്ചിയില്.
ഞാനത് നമുക്ക് അഡോളസന്റ് വലിയ താല്പര്യമുള്ള വിഷയമല്ല. പിന്നെ
വിജയകുമാറേ, നമ്മൾ ഇത് സോക്കോട് ചെറുപ്പക്കാരൊക്കെ വയസ്സന്മാര് VKPയും പിന്നെ TUS ഒക്കെ എങ്ങായി വരുന്നു. എന്താ ഇതിന്റെ എന്താ പറയാ,
നിങ്ങളുള്ള അടുപ്പം കാരണം, നിങ്ങളോടുള്ള സാമീപ്യം കാരണം.
അതുകൊണ്ടാണ് VKP TUS വിളിച്ചേട്ടാ, ചെറുപ്പക്കാരായതുകൊണ്ട്.
നമ്മുടെ 60 വയസ്സുള്ള ചെറുപ്പക്കാര്.
എന്ത് കരുണാകരൻ?
കരുണാകരൻ 8 മണിക്ക് എത്തുമായിരിക്കും. അപ്പോഴേക്ക് കുഴപ്പമില്ല, തുടങ്ങാം. 7:50 തുടങ്ങും സാർ. 7:50 തുടങ്ങി നമ്മ 8 മണിക്ക് പരിപാടി.
എത്ര സമയം?
പ്രസിഡന്റ് വിളിക്കാം.
ടൈം എത്രയാ?
7:46.
ടൈം എത്രയാ ടോക്ക്?
8 മണിക്ക്.
അല്ല, ടോക്കിന് എത്ര സമയം ഡ്യൂറേഷൻ?
40 മിനിറ്റ്സ് ടോക്കും 20 മിനിറ്റ്സ് ഡിസ്കഷനും.
ഇനോഗ്രേഷൻ അല്ലേ?
അത് നമ്മളെ പ്രസിഡന്റ് എത്തിയാ തുടങ്ങലേ. എത്ര ആൾക്കാരുണ്ടെന്ന് അറിയാൻ പറ്റില്ല, അതാണ് ഇതിന്റെ.
പ്രസിഡന്റ് ഒക്കെ കടയിലായിരിക്കും, വിളിച്ചോണ്ട് പോവാ.
ജോണിന്റെ 2 കൊല്ലം ആവുമോ? ഇല്ല അല്ലേ?
പിന്നെ
ജോണി 2 കൊല്ലായി.
വിജയകുമാർ 1 കൊല്ലം കണ്ടിന്യൂ ചെയ്യായിരുന്നു.
അയ്യോ ഇതന്നെ ഇപ്പൊ എങ്ങനെയോ തട്ടി നീക്കുക.
വിജയകുമാർ കാലിക്കറ്റാണ്. അപ്പം
കാലിക്കറ്റാണ് ഇപ്പൊ.
മഞ്ചേരി ആരപ്പോ?
മഞ്ചേരി ഗീത ഗോവിന്ദരാജ് ആയിരുന്നു.
അല്ല, ഒരു ഇവിടെ പോസ്റ്റ് കണ്ടുണ്ടായിരുന്നു കാലിക്കറ്റ്.
വേറൊരു ഇതില് കിട്ടി. ഇപ്പൊ മഞ്ചേരി ആരും ഇല്ല.
അവിടെ പിന്നെ ഗിരീഷ് ഇല്ലേ? ഗിരീഷ് ഉണ്ടോ?
ഗിരീഷ് കൊണ്ട് വന്നു, കാലിക്കറ്റിലേക്ക് വന്നു.
ശേഷം മാറി അല്ലേ?
ഇല്ല, ബാക്കിയൊന്നും ആയിട്ടില്ല.
പേരാ അവിടെ HOD ആരാ?
HOD ഇല്ല സാർ.
അല്ല എന്നാലും ഇൻചാർജ്
ഇപ്പൊ ആ 2 അസിസ്റ്റന്റ് പ്രൊഫസേഴ്സാ ഉള്ളത്.
ഓ അത്രേ ഉള്ളൂ.
അത്രേ ഉള്ളൂ.
തുടങ്ങാം സാറേ, നമ്മളെ പ്രസന്റ് എത്തി. So very good evening, respected President Dr. Ragesh, State President Dr. Vijay Kumar, Chief Guest of today evening Dr. Sumar sir, Professor V.K. Parvati Madam, my friends in IAP, Dr. Johnny, Dr. Pavan, Dr. Srijit, today's moderator Dr. Karnagara, and President-elected Dr. Jose, and my dear friends. So infection and immunization and antibiotics. This is a Thrissur talk series. Today it is 19th series. So I think we are getting very good response from all over India. Today we are lucky to have my mentor in IAP, mentor guru in IAP, Dr. T.S. Sukumaran sir. I welcome all of you. For official welcome address, I invite Dr. Pavan Madhusudanan, the Dynamic Secretary of IAP Thrissur. Over to Pavan.
Thank you, sir. Good evening once again, and welcome to the Infection and Immunization Thrissur Talk Series, the 19th one in the series. So, respected IAP Kerala State President Professor Vijay Kumar sir, State Secretary Dr. Johnny Sebastian, our own dear Ananda Keshavan sir, the past South Zone Vice President and member of ACVIP, the senior pediatricians and dear friends. So today we have our own Professor T.U. Sukumaran sir, the eminent speaker and the past national president of IAP, who was also the national chairperson of the IAP respiratory chapter, allergy, immunology chapter, etc. So he'll be giving a wonderful talk, and we'll have a wonderful academic session on difficult pneumonia, how to manage, which will be the 19th one in the Thrissur talk series. And the talk will be moderated by Dr. Karunagara BP, the professor and the pediatric intensivist and allergy specialist, and he is the president of IAP respiratory chapter of Karnataka, as well as the vice president of IAP Karnataka. So with these words, I welcome you all the senior pediatricians and my dear friends, to the 19th talk series, one in the talk series of infection and immunization. So once again, welcome, and over to the moderator. Thank you.
Thank you, Dr. Pavan. I invite Dr. Ragesh for his presidential address.
Good evening, sir. Respected President Dr. Vijay Kumar sir, Johnny, my friend Johnny, Sukumaran sir, Ananda Keshavan sir, Dr. Karnagara sir, all seniors, colleagues, friends. It's a much awaited talk series, because right now we are in the midst of difficult pneumonias, difficult wheezes, difficult bronchiolitis, and everything seems a little bit more complicated than the usual pre-COVID times. So and last time Dr. Sukumaran sir, I had a conversation with Sukumaran sir. He gave me a few tips which actually helped me in the practice also. So I'm looking forward for sir's talk. And once again, thanks to Dr. Ananda Keshavan sir for beautifully planning this timely session, as usual, the much needed one right now. So thank you, sir, and over to Ananda Keshavan sir.
Thank you, Dr. Rakesh. I invite Dr. Vijay Kumar, our state president and chief leading pediatric endocrinologist in the state. Above all, my classmate and my close friend, to give the inaugural address.
Respected T.U. Sukumaran sir, professor, and the apt person for today's talk, the difficult pneumonia. As Dr. Rakesh was telling, everybody is finding difficulty for dealing this case of pneumonia and bronchiolitis has now emerged just after the COVID pandemic. So then, respected Dr. Ananda Keshavan, my friend, my classmate, and the past vice president, ACVIP member, Dr. Johnny Sebastian, secretary, IAP Kerala, the pillar behind all this program, my best friend, Dr. Nandan, Dr. V.K. Parvati Madam, Dr. Rakesh, Dr. Pavan, Dr. Srijit, and Dr. Karunakara, and all the dignitaries, and my dear friends. Today, as I discussed, this is the 19th program of IAP Thrissur on immunization and infection. And this is the most sought after program of IAP Kerala nowadays. And today, sir, I am sure that sir will be dealing with the difficult pneumonia, which will be very practical. And we are in the midst of difficult pneumonias. So that will be of great help to us. I wish the program all success. Jai Hind and Jai IAP.
Thank you, Dr. Vijaykumar. Now I invite Dr. Jose to give his keynote address. He was the past president of IAP Respiratory Chapter, secretary of IAP Respiratory Chapter, now national president of IAP Allergy Chapter, and he is president elect. And so many credentials to Dr. Jose. Over to Jose.
Thank you, Anandageshwan sir, for a very nice introduction, and all the best for the Thrissur series for the excellent topic on every monthly CEM program. I think our respected our mentor and our past president of IAP, national chairperson, Dr. Sivan sir, my guru. Moderator is very another important person from very close friend of IAP. I think Dr. Vijaykumar, Dr. Asin, and Dr. Rakesh, IAP Thrissur and IAP Kerala. I think today we are going to discuss an important topic, as Dr. Vijaykumar mentioned. Now we are facing previously pneumonia post-COVID era. Symptom, difficult pneumonia management. Patient is our guru, Dr. Sukumaran sir is here. I think all of us regarding how to practice. I wish all the best for program. Jai Hind, Jai IAP.
Thank you, Dr. Jose. Now I invite our state secretary to say a few words. Dr. Johnny Sebastian.
Good evening all. Respected chair and my friend Dr. Rakesh, esteemed faculty of the day, Dr. T.U. Sukumaran sir, past national president, a don in the field of pulmonology, as well as one of the most sought after speakers in the field of pulmonology at the national level, Anandageshwan sir, past national vice president, as well as the member of ACVIP, the vibrant secretary of IAP Thrissur, Dr. Pawan, my leader and guide, the state president Vijaykumar sir, Dr. Srijit, who is coordinating the this talk series, my well-wisher in IAP and President-elect Joe sir, Parvati madam, Nandakumar sir, the moderator for the day Karunakara sir, and seniors and dear delegates. At the outset, let me congratulate IAP Thrissur as well as Anandageshwan sir for coordinating the entire series, this infectious and immunization series of Thrissur talk series had been going great since its inception, and now we have reached the 19th episode. And every time the topics are so meticulously selected that the whole IAP Kerala audience is waiting for the topic at this particular talk series. And today we have none other than Sukumaran sir, and as all have already highlighted, we are going through a very difficult phase in dealing with respiratory illnesses, recurring respiratory illnesses, bronchiolitis, as well as difficult pneumonias. And we have none other than Sukumaran sir to enlighten us on this topic. I wish this webinar all the very best. Thank you. Jai Hind, Jai IAP. Thank you.
Nanduma? Nanduma, I think he left. So, Nanduma, so I invite a national EB board member from Kannur and the energetic IEPM from North, Dr. Nanduma, to say a few words. Nanduma.
Good evening, respected President Dr. Rakesh, Dr. State President Dr. Vijaykumar sir, respected Sukumaran sir, and the program coordinator and the energetic Anandageshwan and other dignitaries on this platform. I really congratulate IAP Thrissur for regularly conducting this series on immunization and infection. This is actually the need of the hour. As you all know, the COVID, after post-COVID, we are getting lot and actually all these pediatricians, OP and hospitals are flooded with respiratory infections. So it's an apt time to discuss this topic. And today we have none other than the doyen in the field of pediatric pulmonology, Dr. Sukumaran sir, for this discussion. So I wish all the very best for the program. Thank you. Thank you very much.
I invite Dr. Srijit to propose the vote of thanks.
Thank you, sir, for inviting me. And as all the panelists, senior panelists have said, this is the 19th episode, and this is a much anticipated episode. And we are waiting for this topic ever since the topic of difficult pneumonia is announced. We have much interest created among our regular audience. So we are privileged to have our Dr. T.U. Sukumaran sir for presenting this topic. And I also thank Dr. Karnagara sir for moderating this session. So welcoming, thanking Sukumaran sir and Karnagara sir for accepting our invitation to have this session. And also thank the IAP Kerala Office President, Dr. Vijaykumar sir for inaugurating this session, and also thank Dr. Johnny Sebastian sir, and thank Dr. Jose sir and EB member Dr. Nandakumar sir, and also thank the IAP Thrissur office bearers Ragesh sir and Dr. Pavan, and the senior members Dr. V.K. Parvati madam, and all the delegates who are regularly attend to our program. And so thank DAP for providing this wonderful platform for taking this serious to a national level and to this 19th episode. So, and last but not the least, the chief coordinator, the mentor of this program, Dr. Anandakeshwan sir, for arranging this wonderful program. Thank you, sir, and over to you, sir.
Okay, thank you. So we'll start our scientific program now. As already mentioned, we have a difficult problem, but I think definitely our Sukumaran sir will solve the problem without much difficulty. And at present, in the scenario in Thrissur and everywhere in Kerala, 60% of the cases are occupied with pneumonia, especially small children, because it may be bronchiolitis, it may be viral, it may be, I think what we have experienced is majority of them are viral pneumonia, but somehow people are forced to start antibiotic. Yesterday we had a IAP Thrissur meeting, and even the people are saying that they start the IV methylprednisolone, magnesium sulfate, so many things are there. So very difficult situation, how to manage. And even the rational practitioner also supposed to give rational treatment in the form of antibiotic and steroid. In this scenario everywhere. And fortunately, there's not much death because all of them are improving. And a small percentage requires some form of ventilation support. Another thing is that we have to be aware, because in this issue we got 4 or 5 cases of H1N1 also in between, and also RSV virus also. We got isolated. By the time we are getting a report, that is pneumonia also. So today the what is from here, sir. I invite Dr. Karnagara of Ramaya Medical College. How do we, because and another the chief coordinator to ban national football. He is for vice president of IAP.
Hello. Hello.
Hello.
Audible.
Yeah. I could hear actually. Basically, it was a signal problem. Yeah. Should I introduce sir actually? So I take this opportunity. Good evening, everybody. It's been a great honor to moderate the session for our Sukumaran sir. He's one of the most favorite presidents of IAP actually. I had an opportunity to work with him, the way he guided us, the way he handled IAP, Central IAP. It's been exemplary actually. So I still remember the great work done by Dr. Sukumaran sir actually, and including family benefit scheme, and the credit goes to Dr. Sukumaran sir. So today we have an opportunity to listen to the lesson from himself actually, to learn about the interesting topic. So I'm looking forward to listen to you, sir. It's over to you, sir. Thank you, sir.
Okay.
Dr. Anand Keswan?
Yeah.
Share the slides. No?
So can you see the slide?
I will change. There is some problem in slide changing.
Then I am sharing for you, sir.
You do not share. I will do it.
Okay, sir. Okay, no problem. I thought you told me to share this one.
No, I will do it.
Clear answer. Clear answer.
Just you are just visible. As beloved chairperson, my close friend, Dr. Karnakar from Bangalore, Dr. Anand Keshavan, State President Dr. Vijay Kumar, State Secretary Joni, IAP Thrissur President Dr. Ragesh, Secretary Pavan, Dr. Parvati, Dr. Jose, Dr. Purushothaman, and other senior faculty members, and my dear friends. Let me at the outset thank my beloved friend, Dr. Anand, for giving this opportunity to talk to you. And also, I congratulate the Thrissur team for doing this wonderful webinar series on infection and immunization. And this is 19th episode. I have great pleasure to welcome all of you for this program. As Dr. Nandakumar said, we are going through a period of difficult pneumonia, difficult bronchiolitis, difficult asthma, and I think all the respiratory problems are difficult to treat now. And I will just try to discuss about the management of difficult pneumonia to some extent in the next 40 to 45 minutes. As you all know, pneumonia is the commonest respiratory problem that we face, especially during this season post-COVID. And pneumonia accounts for more than 19% of the under 5 mortality. Why 19%? Why these children die? These children die because the delay in diagnosis and delay in starting antibiotic. If you start antibiotic very early in a bacterial pneumonia, we can save number of children. And I just go through a case scenario of difficult pneumonia. This is a case of a 5-year-old male child who was presented with fever, cough since 3 days, difficulty in breathing for 1 day. Here a respiratory rate of 50 per minute. LNA flare was present and there was lower chest contraction. And on examination, bronchial breathing was present, and fine crackles on the left upper zone, and there was no murmurs on auscultation. So this is a very simple problem, very common problem. 5-year-old child who is presented with fever, cough, and respiratory distress. I think there is only one diagnosis in a child who is presented with fever, cough, and respiratory difficulty. The first possibility should again be pneumonia, especially in presence of a respiratory rate of 50. This child is having tachypnea and lower chest contraction. And tachypnea is the most sensitive sign for diagnosis of pneumonia in a community setup. But in a medical college setup, we must always look for other clinical evidence of pneumonia, like errantry, bronchial breathing, and crackles before we make a clinical diagnosis of pneumonia. So this child is having a pneumonia. And where is the pneumonia? Pneumonia is mainly in the left upper lobe. And how will you proceed now? We are taking X-ray of this child. X-rays are actually not very much necessary if you can make a sure clinical diagnosis of pneumonia. The X-ray shows a pneumonia of the left upper lobe. There's a left upper lobe consolidation, and also you can see air bronchogram also here. So it's a very typical lobar consolidation of the right upper lobe. The commonest organism which produces a lobar pneumonia is usually pneumococci or H. influenza, but rarely other organisms can also present with the lobar consolidation, like mycoplasma also rarely. And this child was admitted in the hospital, and as usual, child was put on a high dose of ampicillin, 100 to 200 milligram per kilogram body weight. And usually in a child with a pneumococcal pneumonia or a lobar pneumonia, they respond within 48 hours. Usually, the response is in the form of they become febrile within 48 hours. The respiratory rate comes down, and later the lung signs disappears. And X-ray clearance may take some more time, but a repeat X-ray is not required if a child is improving very well. But unfortunately, in this child, On the third hospital day, the fever was persisting. There was no improvement in the respiratory symptoms and signs. Now, what are the possibilities? Child with a lobar pneumonia presenting with a persistent fever on the third day. Then you must think of a difficult pneumonia in a child like this. So you must think of some of the complications. Examine the child very well. Examine for a diminished air entry. Purpose such as for an evidence of effusion. So you may empyema, or the child may have infection with a resistant organism. The pneumococci may be resistant to ampicillin or ceftriaxone. So it may be a resistant organism, or it may be produced by other rare organisms like Mycoplasma pneumonia. Mycoplasma pneumonia is a very common organism that produces pneumonia in children above 5 years. It is reported that more than 25 to 30% of cases of pneumonia in children above 5 years in the school age group may be due to Mycoplasma. We thought Mycoplasma will produce an interstitial pneumonia, but now we are seeing cases of lobar consolidation and even effusion and empyema with Mycoplasma pneumonia. So what do you do for this child now? We'll repeat a CBC, repeat an X-ray, and do an ultrasound test. The most important is ultrasound test. And since you consider the age of the child and poor response, you must look for Mycoplasma also, look for Mycoplasma serology. Again, the CBC shows mild anemia. Total count is still high with 70% polymorphs. And X-ray again shows the same clinical picture. There is no resolution of pneumonia. Ultrasound showed no fluid in the chest. There is no effusion. So this child has not responded to ampicillin. So what do you do now? And so we must switch over to a second line therapy. The second line drug may be a ceftriaxone for the possible resistance of pneumococci to penicillin. So we must start with ceftriaxone, and we may have to add a macrolide, especially azithromycin 10 milligram per kg for day, daily for 3 days, or clarithromycin 50 milligram per kg per day, BD for 14 days, since we are suspecting a Mycoplasma pneumonia in this child. This child has responded to this combination, and meanwhile the Mycoplasma IgM has come to positive. So this child has a difficult pneumonia. Most probably, even though the commonest organism that produces a lobar consolidation like this may be pneumococcal pneumonia, but rarely Mycoplasma can also present like this. So I have looked at the definition of difficult pneumonia, but there is no definition of pneumonia, the difficult pneumonia. But there are some of these features are there. If a child is having a persistent fever, more than 72 hours, usually in a child with a pneumonia, usually they respond within 48 to 72 hours. With fever is persisting after 72 hours. If a child is having a persistent tachypnea, you count the respiratory rate and child is having a persistent tachypnea, and if the child is having a persistent desaturation or persistent lung signs, then the child may have a difficult to treat pneumonia. Now, pneumonia is a clinical diagnosis. So how do you make a diagnosis of a clinical diagnosis? And there should be some clinical clues in the etiology. If you take a detailed history, and investigations are not very, very important in the diagnosis of pneumonia in a child. Clinically, as I said before, the most sensitive sign of pneumonia still is tachypnea in a community setup. What is tachypnea? If the respiratory rate is less than more than 60 per minute in a child less than 20, less than 2 months, more than 50 in 2 months to 12 months, and more than 40 in 12 months to 5 years. And if it is more than 30, above 5 years, you can suspect tachypnea. And the sensitivity is nearly 74%, and specificity is 67%. This is a very important clue for diagnosis of pneumonia. But in a medical college setup or in a hospital setup, you must also look for other clinical evidence of pneumonia in a child. But there is no problem in making a diagnosis of pneumonia by tachypnea alone, because we'll be overdiagnosing pneumonia if you are going by tachypnea alone. But I think there is no problem in overdiagnosing pneumonia, because as I said before, the commonest cause of death in a child with pneumonia is delay in diagnosis of pneumonia and delay in starting antibiotic. If you diagnose pneumonia very early and start an antibiotic, we can save most of these children. So there is no problem in overdiagnosing pneumonia, but because we'll be able to save a lot of children. But you must also think of other causes of tachypnea. Even the commonest cause is pneumonia, but other conditions like bronchiolitis. Now it's the season of bronchiolitis now. Bronchiolitis is again a clinical diagnosis. Investigations are not very much required. A child in the age group of 2 months to 2 years, 2 months to 2 years, presenting with the first episode of wheeze. First episode of wheeze with a viral prodrome. It's a family history of a viral illness in the family. If there's a viral prodrome with first episode of wheezing, you make a diagnosis of bronchiolitis, which may be due to an RSV virus infection, even metapneumovirus infection, rotavirus infection. All this can produce, and also influenza virus can produce bronchiolitis. Again, it's a clinical diagnosis, but there are a lot of controversies in the treatment of bronchiolitis also. In the bronchiolitis, there is no much role for bronchodilators, but if you can have a trial of a bronchodilator. Any child with bronchiolitis, wheezing is there, especially in those children with a positive family history of asthma, you can try with the nebulized salbutamol. Other drugs being tried are, if the child is responding, you can continue with that. Other drugs that may be tried for treatment of bronchiolitis include nebulized adrenaline, nebulized hypertonic saline, etc. can be tried in bronchiolitis, but most of these children will recover within 5 to 7 days. But the main problem is a persistent cough in these children. And other condition that present with the recurrent wheeze, it will be a Waldry, or the current terminology is episodic viral wheeze. A child less than 5 years, presented with the recurrent episodes of wheezing, and at the onset there will be fever, febrile onset, recurrent episodes of wheezing, without a family history of asthma, or without a family history of atopy, or without a personal history of atopy, like atopic dermatitis or allergic rhinitis, then you can make a diagnosis of an episodic viral wheeze. We see a lot of children presenting with episodic viral wheeze, mainly triggered by a viral infection, probably rhinovirus infection, human metapneumovirus infection, etc. But again, it is a clinical diagnosis. These children may respond to inhaled salbutamol or inhaled hypertropium bromide. And those children with severe or recurrent episodes of episodic viral wheeze, severe episodes, more than 3 episodes, which necessitate hospitalization, you may think of a long-term prophylactic treatment, either with a montelukast or inhaled corticosteroid, either budesonide, for a period of 3 months can be given as a trial for treatment of episodic viral wheeze. Other cause for a tachypnea in a child is asthma. Asthma is a diagnosis above 5 years of age. You can make a diagnosis of asthma. If a child is presenting with the recurrent episodes of wheezing, most probably it is asthma. Recurrent episodes of wheezing, which responds to a bronchodilator, or wheezing subsides spontaneously, and with a positive family history of asthma, or with other personal history of atopic manifestations like atopic dermatitis or allergic rhinitis, you can make a response diagnosis of asthma. Other conditions that can present with tachypnea, rarely these children with metabolic acidosis due to DKA and chronic renal failure, they can present with tachypnea. Now, after the COVID season, we are seeing a lot of children who are presenting with type 1 diabetes and diabetic ketoacidosis. Their number is increasing. And all children with the first episode of wheezing or first episode of tachypnea, definitely must auscultate and rule out congestive cardiac failure. Then once you make a diagnosis of pneumonia, you must try to find out whether the child is having a bacterial or viral pneumonia. Is it possible? I think in our setup, it is impossible to differentiate between a bacterial and viral pneumonia. But there are some clues for a bacterial pneumonia. If a child is presenting with a very high fever, very high fever with shaking, chills, and rigor, with cough with aspiration of resting sputum, and if the child is having a tachypnea, child presenting with chest pain, evidence of lobar consolidation, evidence of a pleural effusion, or empyema, is some predisposing factors like skin infections are there. Most probably it is a bacterial pneumonia rather than viral pneumonia. Viral pneumonia, usually the fever is mild fever, and they usually present with wheezing. The predominant symptom is wheezing, and usually there's a bilateral involvement is there, and X-ray shows a diffuse bilateral infiltrations may be there. But if there is lobar consolidation effusion, most probably it is a bacterial pneumonia. But most of the time, it will end up in starting antibiotics. Antibiotics are required in most of the children with pneumonia, because it is very, very difficult to differentiate between bacterial pneumonia and viral pneumonia. And viral studies are out of questions in our setup. And once you diagnose a community-acquired pneumonia, it can be a typical pneumonia or a typical pneumonia. The typical community-acquired pneumonia, as I said before, as I shown the X-ray, sudden onset, high fever, productive cough, and pulmonary symptoms are dominant, and X-ray shows localized findings with a lobar consolidation. Maybe the common organisms are pneumococci, H. influenza, and staph. These are 3 common organisms. Whereas in a community-acquired typical pneumonia, actually that term is not also very correct. Even a typical pneumonia can also present with lobar consolidation, gradual onset. The main symptom will be persistent dry cough, just like pertussis. They can present with a pertussis like symptom with a low-grade fever with systemic involvement. They can present with skin manifestation, encephalopathy, hepatic involvement. All this can be there, and they are mainly produced by mycoplasma, chlamydia, and Legionella. Now, coming to radiology in the case of pneumonia, is X-rays are good for diagnosis of pneumonia. X-rays are not very much record for diagnosis of pneumonia because pneumonia, they present with clinical symptoms very early. Today I show a child with one X-ray. Just X-ray was taken yesterday. The X-ray is normal. X-ray is normal, perfectly normal. But when I asked to the child had a clinical evidence of pneumonia. So the earliest evidence of pneumonia may be clinical rather than radiological. So radiological appearance occurs later. And also it is said that in some other children, you may take an X-ray, see that X-ray is normal. But after 2 days, the child may show radiological evidence. It is said that in those children who are severely dehydrated with pneumonia, the X-ray manifestation may not be there. Once a child is hydrated, they can present with consolidation, etc. If you see a lobar consolidation as in the first X-ray, maybe a pneumococcal pneumonia, right upper lobe pneumonia in a newborn, maybe an aspiration pneumonia, upper lobe pneumonia with cavitation, bulging fissure, maybe Klebsiella pneumonia. If the child is present with recurrent right upper lobe, middle lobe pneumonia, consider partial obstruction due to lymph node. It may be a box syndrome due to tuberculous lymph node pressing on the middle lobe. Multiple small lobes are there. These pneumatocysts are there. Maybe staphylococcal pneumonia, Klebsiella pneumonia, or invasive pseudomonas pneumonia. There's a bilateral interstitial pneumonia, mainly viral pneumonia. Bilateral interstitial pneumonia in a child with a malignancy, maybe pneumocystis caridinea pneumonia. I will show you some of the X-rays. This child, you can see there is a right upper lobe pneumonia, lobar pneumonia with some degree of bulging fissure is there. Maybe pneumococcal or Klebsiella pneumonia. This child, you can see a middle lobe consolidation is there. You can see the middle lobe. So it's a middle lobe consolidation. Again, it may be due to Haemophilus influenza or pneumococci. This child is presented with severe pneumonia. You can see multiple pneumatocysts are there. So this is a staphylococcal pneumonia. This child, there is an upper lobe pneumonia with cavitation and bulging fissure. So it's a Klebsiella pneumonia. You can see there's a cavitation with actually bulging. The horizontal fissure should be horizontal like this, but there's a bulging of the fissure is there. So this may be a Klebsiella pneumonia. Then coming to COVID and pneumonia. COVID pneumonias are not very common in children. Now COVID has gone now also. CT test is more sensitive than X-ray for diagnosis of a COVID pneumonia. But all children with COVID, you should not go for a CT scan for diagnosis of pneumonia. CT scan is not indicated in children with mild disease, long fever unless lower respiratory symptoms are suspected. For moderate to severe disease with a positive RT-PCR, then you can go for a CT scan. CT is mainly indicated when you suspect clinical COVID-19 with protracted symptom, but negative RT-PCR. Clinically, you suspect an COVID-19, but there is no clinical evidence of pneumonia. You may go for a CT scan. Acutely sick child with breathlessness, where need to determine the cause of illness and triage is needed. You may go for a CT scan. Non-severe COVID-19 with deterioration. So actually, even though CT is more sensitive than X-ray, it is not always required, and COVID pneumonia is not very common in children. Then coming to the antibiotic selection, treatment of pneumonia in children. All pneumonias deserve antibiotic as differentiation from viral and bacterial pneumonia is very difficult. As I said before, most of the time we will be forced to start an antibiotic in children. As identification of the causative bug usually is not possible, the choice of antibiotic is empirical. It mainly depends on the age of the child, severity of the infection, predisposing conditions, and local epidemiological data on antibiotic and antibiotic resistance. Then these are the age-related pathogens in community-acquired pneumonia. First 3 months, the commonest organism is mainly bacterial. Gram-negative organism, Chlamydia trachomatis, then Streptococcus pyogenes and virus. 3 months to 5 years, maybe again virus, but 3 common organisms are pneumococci, H. influenza, then Streptococcus pyogenes and Mycoplasma pneumonia. Above 5 years, the commonest would be pneumococci. Mycoplasma pneumonia accounts for nearly 25%, staph, virus, and Streptococcus pyogenes. So the 3 common bacteria are pneumococcus, Staphylococcus, and H. influenza. From the history also, you must try to get a clue for the predisposing factor for pneumonia. If a child develops pneumonia following a bullous symptomatic or pyoderma or following measles, it may be a staphylococcal pneumonia. In children with HIV, there can be pneumonia due to pneumocystis carinii. Children with neutropenia, they can have gram-negative infections and aspergillosis. Children with cystic fibrosis, they have pneumonia due to Pseudomonas and staph. Children with PEM, they will have severe pneumonia due to gram-negative organism and staph. Aspiration pneumonia is mainly produced by anaerobes. Coming to antibiotic selection in children with pneumonia, for treatment of for selection of antibiotic, I think you can divide these children into 3 groups. What is first group is those children who needs outpatient management, that is children with mild pneumonia or moderate pneumonia. But those children with severe pneumonia, they should be admitted, so they need inpatient treatment. And children with suspected staphylococcal pneumonia. 3 groups are there. Children who needs OPD management, children with IP management, children with severe staphylococcal pneumonia. In those children less than 3 months, should always be treated as inpatients. Well, from this slide, you can see for the outpatient management, again, the first drug should be amoxicillin. Amoxicillin is the best drug and first drug, and should be given in the dose of 30 to 50 milligram per kilogram per day for 5 days. But according to the WHO recommendation, they recommend high dose of amoxicillin, 80 milligram per kilogram body weight, 12th hourly for 3 to 5 days by WHO. For children above 5 years, the first drug is amoxicillin, but those children who are not responding, you may try a macrolide or co-amoxiclav. So the second line may be, and the best drug should be co-amoxiclav. Then coming to the antibiotic selection for inpatients, these are all IAP recommendations. And age less than 2 months, the first line should be cefotaxime with aminoglycoside. It is better to avoid ceftriaxone in children, especially in the first 1 month, because ceftriaxone can produce hyperbilirubinemia. And yesterday I have seen one child with pseudocholelithiasis. After giving ceftriaxone, the child has presented with hyperbilirubinemia and elevated alkaline phosphatase and ultrasound showing calculi in the gallbladder. So it is better to have a combination of cefotaxime with aminoglycoside in children less than 3 months. 3 months to 5 years, and the best combination is amoxiclav, or you can give a combination of ampicillin with chloromycetin. Second line may be co-amoxiclav, ceftriaxone, or cefotaxime. So in this chart, you can see that the first preference is not ceftriaxone. Again, first preference may be a co-amoxiclav. The co-amoxiclav covers 3 main organisms, pneumococci, staphylococci, and H. influenza very well, but with ceftriaxone, the staphylococcal coverage is less. So it's the second option. Children above 5 years, either you can give crystalline penicillin, this is not written here, there, crystalline penicillin, ampicillin, chloramphenicol, amoxiclav, or macrolide if you suspect mycoplasma and pneumonia. Or second option may be ceftriaxone, cefotaxime, and macrolide. If you suspect a staphylococcal pneumonia, you can have a second generation cephalosporin like cefuroxime or co-amoxiclav or a third generation cephalosporin with cloxacillin for MSSA. For methicillin sensitive, you can start with ceftriaxone with clox, or with an methicillin resistant strain, you can start with ceftriaxone or cefotaxime with vancomycin, thicaplanin, or linezolid. Then when you see a child with a difficult pneumonia, the child is not responding, then you must look for other alternative diagnosis. Maybe child may have associated pulmonary tuberculosis, or the child may have an interstitial pneumonia, acute eosinophilic pneumonia, thromboembolism, or systemic vasculitis. These are very rare things. Of this, again, the common thing is pulmonary tuberculosis. This child has presented with fever of 3 weeks fever, cough 3 weeks. You can see the X-ray, which shows a right upper lobe consolidation with cavitation. AFP was positive in this child. So it is a case of tuberculosis. And also a child who is not responding to antibiotic, you must suspect complications like parapneumonic effusion with empyema, lung abscess, necrotizing pneumonia due to PVL toxin, pneumatoceles, and bronchopleural fistula. This is this X-ray. This child has got a empyema. You can see this child has got a pneumothorax with a fluid level here, and you can see the collapsed lung here. This is a pneumothorax. This child has staphylococcal pneumonia and empyema. Coming to the empiric antibiotic therapy. Empiric antibiotic therapy for parapneumonic effusion and empyema. The combination will be cloxacillin with cefotaxime and ceftriaxone. If you suspect an anaerobic infection, you can add clindamycin, and MRSA add vancomycin. And this is what is called a modified Leitch criteria for management of parapneumonic effusion. There are 2 classes. Class 1 is parapneumonic effusion, and class 2 is empyema. All children with suspected parapneumonic effusion, you must take a lateral X-ray. Lateral decubitus view should be taken, and you measure the thickness of the fluid. If it is less than 10 millimeters, you can start with antibiotic alone. If the decubitus view shows a thickness of more than 10 millimeters, you must do a pleural tap and do a pH, glucose, and gram stain. And if the pH is more than 7.2 and glucose more than 40 milligram and gram stain negative, then you can start antibiotic and repeated thoracosynthesis. And pH is less than 7.2, glucose 40, or gram stain positive, you can have a tube thoracostomy with antibiotic. And the second group is called empyema. You have all children with empyema, you must do an ultrasound and look for the amount of fluid, and also you must look for a loculation. If there are multiple loculation is there, you must go for a tube thoracostomy. Or if there are multiple loculation with pleural peel is there, you can try thrombolytics, or other management of choice is video assisted thoracoscopic debridement and decortication. Coming to thrombolytic therapy, in empyema, you can give either streptokinase or urokinase. Streptokinase is given in the dose of 2.5 lakh units, or urokinase 1 lakh units should be diluted in 100 number of normal saline and should be instilled in the pleural cavity, and tube should be clamped for nearly 3 hours. And the number of instillation in streptokinase and urokinase may be around 6 plus or minus 2.16 or 5 plus or minus 2. This is found to be effective thrombolytic therapy in children with loculated empyema. This X-ray shows one of the another complication, difficult pneumonia. You can see the lung abscess here, the necrotizing pneumonia. Lung abscess is there. Then this is again a necrotizing pneumonia. You can see multiple small cavities there, maybe multiple pneumatoceles, multiple small cavities with effusion, higher levels in the axilla. So there is an effusion is there, maybe staphylococcal or maybe due to Klebsiella. This X-ray shows multiple pneumatoceles, or a child with multiple pneumatoceles are there, maybe staphylococcal pneumonia. Again, this child shows a bronchopneumonia. You can see the bronchopneumonic patches on the left side and with a collapse of the left lower lobe, collapse may be there. One of the complications of pneumonia is they can develop associated collapse because thick mucus can compress the bronchus and produce collapse. All white shadows in the chest are not pneumonia. It's always not pneumonia. And also you must think of other mimics. Pneumonia mimics is there. This is thymus. You can see the sail sign is there. And thymus can have a lot of funny shapes can be there. This is what is called a sail sign. And usually thymus disappears by 2 years of age. Again, this child, you can see in uniform opacity. It's a completely opaque left hemithorax. Completely opaque left hemithorax. The mediastinal shift to the left side. There is no bronchopulmonary markings here. This child has got a pulmonary agenesis on the left side, which may mimic a lobar pneumonia with diffusion. Then just present 2 cases of difficult pneumonia. This is the story of a 5-year-old boy who was presented with the recurrent episodes of respiratory infection from 2.5 years onwards. He had 3 episodes of acute otitis media. First episode about 3 years. Each episode was treated with oral antibiotic. Recurrent episodes of pneumonia. And the child was admitted and given IV antibiotic. The second episode, child had a severe pneumonia at 4 years, and sputum culture showed Pseudomonas. If your child sputum is positive for Pseudomonas or blood culture positive for Pseudomonas, again you must suspect an immunodeficiency in a child. And this child had a various courses of antibiotic, and on examination, this child was not growing well with grade 2 PM, and BMI was 11.3. Child had a bilateral clubbing, and there was no lymphadenopathy. BCG scar is absent, and all children with the recurrent pneumonia, you must have a look at the tonsil and look at the lymph nodes. And in this child, the tonsil was hypoplastic, and so when a child has got a hypoplastic tonsil or absent tonsil, you must look suspect A gamma globulinemia. But if the child is having an BCG scar is absent, again, maybe due to a wrong technique, or you can suspect a cell-mediated immune deficiency. The BCG scar is not there. If the tonsils are not there, suspect a gamma globulinemia. And this child had a low hemoglobin, normal counts, ESR was 15, sputum AFB was negative, CB9 negative, Minder was negative. Sputum culture and sensitivity, Pseudomonas aeruginosus was gone. Alpha-1 antitrypsin negative. HRCT showed consolidation involving the posterobasal and medial basal segment of the left lower lobe. Set chloride again, because of recurrent pneumonia to cystic fibrosis, it was negative. We had done a bronchoscopy and bronchoscopic aspiration to look for TB, it was again negative. And again, a clinical diagnosis. Just look at the throat in this child. Throat, you can see there are tonsils are absent in this child. So absent tonsil. Then CT scan shows bilateral bronchiectasis can be there. We went for an immunodeficiency workup. CD20 B cell marker, absolute lymphocyte count was normal. The B cell count was less than 1%. Absolute CD20 was 5%. CD19 total B cells less than 1. Normal is 13 to 27%. Absolute CD19, 6, just less. And so we did an immunoglobulin profile. You can see IgA is low, IgG is low, IgM is low, and IgE is also low. So this child had an A gamma globulinemia. So this is what is called a Button's A gamma globulinemia. And this child is put on IV immunoglobulin. And this child is getting monthly immunoglobulin for the last 2 years. This child has improved very well. The growth was improved, and child has not developed pneumonia after starting immunoglobulin therapy. Monthly immunoglobulin is continued for this child. This is a second case, an interesting child. A 4.5-year-old child, male child, referred with the complaints of fever of 5 days duration, cough of 5 days, breathlessness for 3 days. So fever, cough, breathlessness. Again, a clinical diagnosis. Again, the child has pneumonia. This was during the last flood season. And fever was high grade fever, not associated with chills and rigor, not associated with myalgia or arthralgia. So high grade fever is suspected bacterial pneumonia in this child. Child was febrile dyspneic, a very fast rate, 60 per minute with subconscious traction and desaturation. Child had a normal air entry, bilateral tractures were there, is more on the right side. This child was admitted to local hospital, had a number of antibiotics, child ceftriaxone, azithromycin, just upgraded to injection, piperacillin, tazobactam, antiviral drugs were also given, amikacin also given for persistent fever spikes, cough, and desaturation. Again, this was a very difficult case for us. Child not responding to the common antibiotics, which is given for pneumonia. The X-ray test behavior revealed right middle and lower lobe consolidation and left paracardiac consolidation. We did an IgM ELISA for leptospirosis. It was positive. And we continued with peptas and started with doxycycline. Child became a febrile, child improved. Most probably, this child had a leptospiral pneumonia. Leptospiral pneumonia is very common in adults and is common cause of death in adults due to pneumonia and myocarditis. But unfortunately, this child most probably had a leptospiral pneumonia, but usually leptospira should respond to other antibiotics like ceftriaxone. This child, the response was poor, again proving that this child had a very difficult pneumonia to treat. So again, the X-ray shows a pneumonia here on the right side. The right cardiac body is not seen. So a middle lobe involvement is there. And also you can see there's a lower lobe involvement is there. And again, there's pneumonia in the right left retrocardiac region. Retrocardiac pneumonia is there. So bilateral bronchopneumonia patches were there with very poor response to antibiotic. So again, the child has responded to doxycycline. So these are the HRCT findings in this child. Doxycycline was continued for 10 days. Child improved. Discharged on 13th day. Probably a leptospiral pneumonia in this child. So to summarize, pneumonia is a clinical diagnosis. You suspect pneumonia in any child who is presented with a fever cough. Look at the respiratory rate. If the tachypnea is there, you may suspect a pneumonia in this child. But there are other conditions that present with tachypnea. In our setup now, we are seeing a lot of children with bronchiolitis. First episode of we seeing with a viral prodrome, low-grade fever, 2 months to 2 years. This bronchiolitis. Usually, this child may respond to a trial of bronchiolitis. Then difficult pneumonia, persistent pneumonia. If the pneumonia persists for more than 72 hours, fever persists more than 72 hours. There's a persistent tachypnea is there. If desaturation is there, persistent lung signs are there, you may suspect a difficult pneumonia in a child. So difficult pneumonia should be further investigated and must try to find out a cause of persistent pneumonia. And in this season, I think it is very difficult to treat children with respiratory infection without an antibiotic because we don't know whether pneumonia is bacterial or viral. You may be forced to select an antibiotic depending. The antibiotic selection should be depending on the age of the child, severity of the infection, and treatment should be depending on the severity as an OPD basis, inpatient basis, or if you strongly suspect a staphylococcal pneumonia, you must give anti-staphylococcal drugs. The role of antiviral drugs, I think the role of antiviral drugs is limited. There is no need to give paracetamol for all children with pneumonia. But if a child is having a very strong suspicion of a viral pneumonia with a low-grade fever, very sick child, and if the counts are very low with leukopenia, with lymphocytosis there in the very first smear, you may suspect a viral pneumonia, and you may add oseltamivir for these children. Otherwise, I think you must not give oseltamivir for all children. You must not give for all children with pneumonia. So once again, thank Dr. Anand for giving this opportunity, and thank you very much for your patient listening. I think we'll have time for discussions.
Thank you, sir. Over to Dr. Tanagara.
Thank you, sir. Thank you so much. Sukumaran sir, it is a wonderful talk as we listened to earlier also. It's been refreshing and naturally it opens up a lot of new thinking, and I'm sure it cleared everyone's doubt how to go about with pneumonia actually. Thank you so much, sir. It was a wonderful talk. Good x-rays also, and you also highlighted on IAP recommendation that's been an extraordinary actually. So a few things, maybe there is some question is there to start with. So there is one in the chat box. Actually, somebody has asked why we need to use two medication for 3 months to 5 years. Ampicillin with chloramphenicol. They wanted to know why you require chloramphenicol at that age. Would you like to take up, sir?
Yeah. Okay. See, one common organism that produces pneumonia in this age is H. influenza. H. influenza usually respond to ampicillin and chloromycetin. But all the strains may not respond to ampicillin or chloromycetin. So I think it is better to combine ampicillin with chloromycetin. In this age, if we strongly suspect an H. influenza infection, especially the child is present in pneumonia with conjunctivitis, there are two possibilities. One is an H. influenza, and then other is a chlamydia trachomatis infection. That is why this IAP recommendation, you may combine ampicillin with chloromycetin. But I think the use of chloromycetin is less now. When 20 years back, when we were resistant basal level, we were using a lot of chloromycetin. All these children has responded to chloromycetin. And people say that the plastic anemia is very, very common. But I have not seen much cases of plastic anemia following chloromycetin. We were using chloromycetin in all children with pneumonia previously. Even in the National ARI Control Program also, chloromycetin was there. But meningitis also we were taking ambi with chloro, was the best combination. And these complications are less. But now nobody dares to give chloromycetin. I think in that age, the best combination should be amoxicillin.
Yes, sir. I think nobody uses it now these days, but that may be the reason why in a difficult cases, one should really look at it as an option actually, because not used for a long time, return of sensitivity. There are instances where with typhoid especially, we have seen it responded very well. Actually, I think one must keep that option open. Thank you, sir. I want to ask one more question now. Now that cloxacillin is not available actually, as of now, it's not available. People end up using only either vancomycin or something like this. Would you like to suggest something on that?
Yeah, cloxacillin has come back again.
Okay.
Cloxacillin has come back again.
One brand
is available.
One
brand is available. It's a very good drug, especially when you suspect an methicillin sensitive pneumonia.
It's not
Always
available.
Cloxacillin. It's available now.
A new brand came up, sir. A new brand.
Sir, widely actually. So people end up using either. Okay.
We do not go for vancomycin.
Sir, one thing was
trichoplan.
Now that, as I told already, that clox is not easily available. If it's come back, it's wonderful actually, because at some point of time it has become quite rampant using vancomycin actually.
Yeah.
These days, people add vancomycin as if like an add-on drugs for management of pneumonia. Would you like to comment on that, sir?
I think it should not be, vancomycin should not be an add-on drug. I think vancomycin should be selected for only an methicillin resistant pneumonia or meningitis. Routinely should not be given vancomycin. And also the main practical problems with vancomycin are, it is very difficult to keep an IV line. Thrombophlebitis is very, very common, and other complications are common with vancomycin. Red man syndrome is there. And most important thing is that giving vancomycin for 7 to 10 days will be very difficult.
Yes, sir. But now, as I told already, because non-availability of cloxacillin has forced people to use it rampantly. Actually, that's a concern. Sir, one thing I want to ask you again is, like, say, in the absence of easy availability of cloxacillin or its derivative, do you suggest we go with cefuroxime as one of the useful drug in the management of staph pneumonia?
Yes, definitely. Not only staph pneumonia. See, in children in the age of 3 months to 5 years, I think it is better combination will be a cefuroxime rather than ceftriaxone or third generation cephalosporin, because cefuroxime mainly cover pneumococci, then staphylococci also, and also H. influenza. The staphylococcal coverage is better with cefuroxime, second generation, first generation cephalosporin. So I think it's a better drug when compared to ceftriaxone, even for staph pneumonia also.
Okay, sir. Sir, next question I would like to ask. Yeah.
There's 2 questions, sir. Can I ask, sir?
Yes,
Hello?
Anand Kishore, sir, you can go ahead.
Yeah. So, sir, it's really a wonderful talk. I have 2 questions, sir. One is regarding any change in the scenario, in pneumonia, etiological age scenario following the vaccination, because H. influenza and pneumococcal vaccine, even though non-typable H. influenza is there, and also many strains are not covered with the pneumococcal vaccine, that we know. But then also, we are not coming across with, I think, lobar pneumonia is a very rare H influenza, we are not getting any evidence. We are getting more mycoplasma pneumonia and viral pneumonia nowadays. Anything like that?
See, but the most important thing is that we have no evidence for the incidence of pneumonia. But because we have done a study in Pushpagiri Medical College on etiology of pneumonia, especially for pneumococcal pneumonia. Out of 100 cases of pneumonia, there was no case of pneumococcal pneumonia there. This is the main problem with the culture was that most of the children are referred cases from the periphery. In the peripheral hospital, all people are getting amoxicillin. So once you receive amoxicillin, the culture will become negative. So out of 100 consecutive cases, our culture positivity was nil. There was no case of pneumococcal pneumonia in 100 children. Maybe one reason may be because of the amoxicillin. Second reason may be the high vaccination coverage. Maybe a second. But the study from by Dr. Subramaniam and others from Chennai, from Kanji Kamagodi, they have seen they are getting more cases of culture proved pneumococcal pneumonia there. But our culture positivity was very low. Only among the 100 cases, there was no culture positivity for pneumococcal. But pneumococcal pneumonia is less now. As you correctly said, we are seeing more children with mycoplasma pneumonia. Those children was presented with the recurrent bouts of cough. Older children, just like a pertussis syndrome, with the involvement of all family members, maybe mycoplasma pneumonia.
And if there is no notification by WHO or Health Ministry about H1N1, how much we justify using oseltamivir?
That I'm saying. I think if you strongly suspect one outbreak, during outbreak we can give. But now what?
I agree, sir. But
now we have seen that all children coming to the OPD, they are going with oseltamivir, especially in all the government hospitals. I think government hospitals now, oseltamivir is very freely available now. I think so. I'm not working in a private setup. But so most of the children, we get the OP ticket, they are getting oseltamivir, they are routinely given. I think this routine is not required. If you strongly suspect it in a child who is not responding to antibiotic, if a total count, you have done a total count. If there's a leukopenia with lymphocytosis, maybe viral, then you can start. May start antiviral.
Whereas I inviting Dr. Srinivasan sir, our regular attendee, Dr. Srinivasan sir, sir, Srinivasan sir, Dr. Srinivasan.
Yes, muted.
Yeah.
Okay.
Hello.
Okay,
Yeah.
sir. Okay, sir. Welcome.
Yeah.
Srinivasan, sir.
Yeah. So I was listening to your talk, excellent talk on pneumonia and all areas covered. So wonderful. Can you hear me?
Yes, sir. Yes. Audible.
Yeah. A fantastic this thing, a collection of various aspects of pneumonia and its management. Thank you. Excellent exercise.
You are in the States, sir? You are in the US now?
Yeah. I am now in Connecticut. Yeah. I am returning on 10th September.
Okay, right. I have seen your letter yesterday also. I have seen WhatsApp message from you.
So you are conspicuously missing. You know, you are one of the pioneers in pulmonology.
Okay.
You have brought out you have given me a copy of yours long back.
Okay, thank you, sir. Thank you, sir.
Yes, sir. Now I am inviting Dr. Purushothaman. I think he's a great academician teacher. From now he's in Malappuram. So we don't know any changing trend of pneumonia due to some.
Due to shifting to Malappuram.
Yeah, immunization and pneumonia.
Thank you so much, sir, for that wonderful talk. I to add just a few comments about the clinical aspects, the investigations, and the management part. Your last case of the presentation of leptospira, and that is one thing. And one more thing to be added here in Kerala nowadays, rickettsial also, sir.
Oh, right.
So there's a more and more number of cases of rickettsials we are getting, and In that way, doxycycline is justified. Otherwise, it's an overused drug during this COVID season, but here it is justified. Few general points about the pneumonia. The atypical pneumonia presentation, few things the beginners should be checking in the general examinations. One is for the rashes, the other is for the eyes for the conjunctival congestion. Another thing is for the muscle tenderness and the joint examination, and a little rare chance of a tinge of jaundice and relative bradycardia. Because the atypical organisms, there can be some clues. Legionellized one where we see very rarely only. We usually describe it, but you rarely see. The clue is there can be a loose stools and a little bit of sometimes altered sensorium in a case of this Legionella, and the can be a septic meningitis in leptospira also. So loose stools and altered sensorium is to be checked. Relative bradycardia, especially in the case of Legionella, and rashes in almost all the cases like Legionella, leptospira, rickets cells, mycoplasma, uroplasma, everywhere some type of a rash is to be checked. And this can be a clue. Muscle tenderness in Legionella, mycoplasma, and the leptospira also. Conjunctival congestion also, all these three things. So general examination, these clues may be searched because sometimes typical organisms can be useful. About the diagnostic part, sir, you said about the lights criteria and is above or below 10 millimeters. But nowadays, more and more cases of X-rays are being taken by digital. So
right.
It's time to change that criteria of that 10 millimeters. Otherwise, it should be mentioned that it should be corrected for that digital technology. All the criteria need to be revised. Regarding a management, sir, the point well taken, because we have been getting good result with the CP and chloromycetin and cetran one time in different stages of pneumonia. And once you dropped it, it's forever. You are not utilizing that. I think there can be a change in the sensitivity coming back when we are not using at all that drugs. We were using CP, but nobody is using CP now. It's a good drug. For pneumococci, there is no gram-negative coverage, but that's a good drug. We used to get a good response with CP. And definitely chloro is theoretically mentioned, but nobody is using. So everybody is using and going for subtraction only. If you analyze the actual drug usage, the ampicillin, as you said, the first step ampicillin, then only worsening subtraction. It's actually first line subtraction in most of the cases. So gradually, this should be discouraged, and we should be using the once in a while the chloromycetin usage and maybe subtran usage, because sensitivity may be coming back. We may not be knowing that. That's all, sir.
Yes, thank you, Vishnu. Thank you. Hey, Parvati madam.
Yes. Yes. It was an excellent talk, Sukumaran, as usual. And regarding this vaccination, when with this pentavalent vaccination, Haemophilus influenza and Haemophilus influenza has come down quite a lot, no? Is it not?
Yeah.
And now we have got pneumococcal vaccination also. So that also is taken care of. So viral pneumonias are more common, but I think oseltamivir is one thing which is overused. Very often it is overused. I think so. And regarding the mycoplasma pneumonia, Purshu, what I said is excellent. And vancomycin is also often misused. And I think cotrimoxol is a good drug for resistant staph, it seems. Any comment on that, Sumar?
Now also same with cotrimoxol. Nobody uses it, but it's not available also. It is not
available also.
It's difficult to get it. Difficult to get it. Maybe because of the
we are not using frequently. That is why it is not available now.
Yes,
Even-
because of hypersensitivities, so many doctors had been to court because of its use. And Steven Johnson syndrome, that may be the reason. Chloramphenicol also, this aplastic anemia is a little bit overemphasized, I should say. We haven't seen it. We have been using it quite a lot during our early years. Not now, of course. Thank you.
You asked questions and you answered also. Mycoplasma, both Steven Johnson syndrome following cotrimoxazole as well as aplastic anemia following chloramphenicol. So these are two things which keep them, frightened to use them again.
But chloramphenicol is, of course, a good drug.
Wonderful drugs, sir. Very wonderful drugs. Even typhoid fever, some Russian case even rushed to septic. We are getting very good results.
Now its sensitivity pattern has come. It is sensitive. Now it is sensitive. Nice to meet you, sir, in Connecticut. Sir is in Srinivasan sir is in USA.
Yeah, my daughter's place. Yeah. So,
any insight into pneumonia management in US? Nowadays there is 100 cases of respiratory cases. 100% patients are coming with the chest X-ray. No inspection, palpation, percussion, auscultation. Students don't know what is the bronchial breathing. What types of bronchial breathing they don't know, and what is bronchial breathing, and what is the importance of they are not percussing. Of course, very difficult situation. Below 180 is there, but everybody is directly going for X-ray and repeat X-ray after 2 days, after 3 days, repeat X-ray. Same shadow persisting, same another antibody continuing. So all this is happening. I think it is a phenomenon all over the, at least in Kerala.
Not only in Kerala, it is people like the medical college teachers. They should insist and they should teach them. Don't take too much X-rays. Every visit, not X-ray. Even in pneumonia also, a repeat X-ray. Once you are taken X-ray for confirmation, you may take. A repeat X-ray is not required. In a child with pneumonia, who has responded very well. But in a child with a recurrent pneumonia, we may take a repeat X-ray. Otherwise, there is no indication for taking a repeat X-ray. Not to take frequent X-rays.
can I ask questions, Sukumaran sir?
Yes, sir. Yes, sir. Yes, sir.
How you retain your youth? No, you are still the same. I have been seeing you for so many years, but you haven't aged.
Oh, thank you, sir. Thank you, sir, for the compliment, because I am my company is youngsters like Ananda Keshavan is there. Then all these youngsters are with us, so we remain.
Sukumaran sir, a question to you.
Yeah.
So now that basically, as Madam is also pointed out, now with a good vaccination coverage, possibly we don't see the possibility of H flu infection or even pneumococcal infection most of the time, actually. Is it the time where we need to come out with some new epidemiological data and also possibly new recommendations on the medications, antibiotics?
I think we have to modify we may need to modify your antibiotic later, antibiotic policy. I think this policy was written by IAP some 3 years back. I think some changes are required. But most of the antibiotics, most of these children with pneumonia, they respond to this selection of antibiotic. They respond to either amoxicillin or amoxiclav. It's the commonest antibiotic that is available. They respond.
So more than response, what I'm worried about is basically now like you have like places like in Kerala and some of the places where vaccination coverage has been extensively good actually. The chances of a child developing either a H influenza infection or maybe to a great extent even pneumococcal infection has come down significantly actually. But on the contrary, doctors continues to use the same recommendation for prescribing medications, including whatever we discussed now and maybe more than that. So I think possibly there is a scope for relooking at and say where exactly we need to consider antibiotic. Because if you look at the current literature, also basically they say the pneumonia is more often due to viral pneumonia. But nobody says when you not use antibiotic actually. That's the question.
See, Karnagar, I think it is very difficult to, the difficult situation is that it is very difficult to not to start antibiotics. See, most of the times we'll be forced to start antibiotic, especially small children will not wait. Very difficult. So I think all pneumonia should be treated as bacterial unless otherwise put.
Thank you, sir.
The WHO will change the ARA guidance because we are getting, as we know, around bronchitis, asthma, all things lead to high respiratory rate. So over treating with antibiotic, how can we justify WHO guidelines also? Even though we are over treating pneumonia, that's true, but that is not even so. Professional bodies also supporting use of antibiotics.
See, according to WHO, now they say it is a fast breathing pneumonia, chest indwelling pneumonia, and severe pneumonia. Again, depending on the respiratory rate. I think for a community setup, it again holds good. And the drug of choice is again amoxicillin for fast breathing pneumonia and chest indwelling pneumonia. It is again amoxicillin high dose, 80 milligram per kilogram body weight. That is only for 3 to 5 days. 3 to 5 days only. 3 to 5 days.
So that means we can treat all bronchitis, bronchial asthma with amoxicillin.
No, it is not like that. See, bronchial asthma is again, see, we have to differentiate asthma from pneumonia. I think it is not difficult to differentiate asthma from pneumonia. If a child is present with a high fever with tachypnea and chest signs are there, mainly crackles are there, it is pneumonia. Child present without low-grade fever, wheezing, bilateral wheezes, it is asthma. I think it is not very difficult to differentiate clinically between these two entities. And response to bronchodilator.
Okay.
With permission from Karnataka, sir, can we wind up?
Sir, just a moment.
Yeah. Yeah, you
So
can
basically, so I want to ask you basically, Dr. Sukumaran and Dr. Anand Keshwan also, like now, one of the problem we encounter is with the X-rays actually. But these days, as we are discussing now, there is some concern about there is increasing incidence of viral pneumonia, possibly the reporting by radiologists or maybe a little bit more orientation that a lot of streaky thing which could we see on the X-ray could be viral pneumonia may help us in making some decision. Sukumaran sir?
See, I think again, viral pneumonia is a clinical diagnosis. No, it is a clinical
Yes, sir.
diagnosis. With most of the children with bronchiolitis and viral pneumonia, there will be bilateral diffuse infiltrations may be there, perihilar haziness should be there. I think it should be taken as viral. But there is no typical radiological evidence in the viral pneumonia. But if you see a lobar consolidation effusion, it may be a bacterial pneumonia. I think Anand Keshwan is an expert. He was taken a book on radiology of pneumonia. What is your impression? Anand?
Yeah. Anand Keshwan,
Yeah, very easy. I think we are diagnosing cases with X-ray only. Means, there are so many cases of viral pneumonia in the world. We'll clinically suspect it, we'll take X-ray, we'll stop antibiotic. Very good response.
Yes,
so
sir.
we had done child pneumonia in childhood from 6 months to 5 years of age with Dr. Matram Santosham of John Hopkins in Jipmer. So 30% of pneumonias with definite consolidation like any other bacterial pneumonia, 30% of them grew virus, commonest of. So very difficult sometimes to differentiate from these things. Probably more clinical features may be more important.
Okay, sir. Thank you, sir. Dr. Anand Keshwan sir, if there are no questions, it's back to you now.
Yeah. So thank you, Dr. Sumar sir and Dr. Kanara for official vote of thanks. Once again, I invite our program coordinator, Dr. Srijit Kumar, Associate Professor of Pediatrics from GMC Thrissur.
Okay, thank you, sir, for once again inviting me. And this is how this comes to an end to our 19th episode of the Thrissur Talk series. And as I anticipated, this is a much interesting and enlightening talk from Dr. Sukumaran sir. So I thank Sukumaran sir and for this wonderful talk. and also thank Dr. Karnagarar sir for moderating this session well. And we have post-talk, we have a wonderful discussion by participating by Dr. Purushothaman sir, Dr. Srinivasan sir. So I thank all the senior faculties present in the dais. So thanks once again for all the delegates who have joined for this program. And I hope you to join with us in the next episode of the Thrissur Talk series in the last Thursday of next month. So once again, thanking you, and Jai Hind, Jai IAP, and good night.
Thank you, sir.
Okay,
Kumar,
Karnagarar.
sir.
Thank you,
Thank you,
Karnagarar.
sir.
Okay.
Thank you, Sukumar
Srinivasan,
sir.
sir. Yeah. Thank you.
Srinivasan
sir.
sir.
Yeah.
Thank you so much. Thank you, sir.